I think MR, we've been doing cardiac MR, well, since the mid-'80s, something like that. As soon as MRI was possible, people started imaging the heart with it. Obviously, in the early days with MRI, it took quite some time to make a single image. Because the early scanning techniques are fairly slow. So it was difficult to make cardiac pictures, but gating to the ECG is something that was done early on, and reasonable pictures were made very early. I think in the 1982 issue of Scientific American, which is where I first read about MR, I think there were cardiac pictures in that article, if I recall appropriately. So it's been a target for some time, and it's, you know, a reasonable target in the sense that you get a full field of view picture of a patient regardless of their body habitus, you know, or whatever their BMI is or anything. And so when you're trying to make an echocardiograph of larger patients, sometimes it's very difficult to get enough energy in through the tissue to see the heart, except on MR, basically radio waves don't get attenuated that much by tissue, and so you have a fairly transparent view, and you can get these remarkably different contrast images by simply changing the pulse sequence. So we saw in our principles, you can make blood in the descending aorta entirely black, dependent on the flow of that blood, or entirely bright, you know, dependent on the flow. This is called a gradient echo image, and then if you use what's called a steady state image, you can make blood extremely bright as well as fat. So there's a complex relationship between the underlying NMR relaxation parameters and the brightness of the pixels on the image. You can see also, it's worth noting here on a spin echo image, the contrast from the cerebral spinal fluid is quite dark here. In fact, it's probably negative. Here, it's somewhat in the middle of the road, and here, the cerebral spinal fluid is extremely bright. Right? And so these are three different contrast mechanisms. So just to review quickly how the images traditionally have been made is with a spin echo pulse sequence. Recall we apply a 90-degree RF pulse to take the magnetization from the Z direction down into the transverse plane. Once that magnetization is in the transverse plane, it will create a signal. We can then use a 180-degree pulse, a time TE divided by 2 after, to refocus the magnetization vectors at a time TE, such that they all come back into alignment. They all have the same phase angle at this time TE. That causes a signal in the transverse plane, and that signal is used to make the image. The position of magnetization vectors in the volume are encoded by the application of magnetic field gradients, which changes the phase of the magnetization vector in the transverse plane. And that phase is changed because the frequency at which it's processing changes depending on the magnetic field. And so if I apply a gradient in Y, for instance, magnetization vectors higher up in Y will process faster than those below. And then after this pulse is finished, it will leave a residual phase shift that's proportional to the position of the magnetization vectors. So in that way, you can select a slice in Z, so we have Z resolution. You can phase encode in Y. That's make this phase shift as a function of Y. And then you can phase encode in X, so you make their phase also a function of their position in X, and you measure the signal as that phase is evolving, right, over time. So as that X-dependent phase shift changes, you measure a signal here. And then that's equivalent to saying, I will measure an oscillation of a magnetization vector at one frequency and another frequency over time. So here's our signal. This is usually obtained over about a millisecond or so, on that order, 1 to 5 milliseconds to collect all of this signal here. This delay time is usually on the order of 10 to 100 milliseconds, this TE time. And the longer you make it, the more tissue that has short T2 decays away and becomes dark, and tissue that has long T2 remains bright. And so cerebrospinal fluid, for example, remains bright for a long time. And so it shows up bright on long TE images. So can we make an image just using this signal here? So we have signal after this first RF pulse. The magnetization vectors are in the transverse plane. They're oscillating. They're giving us a signal. Can we make a picture just from this signal? And the answer is yes. And we have to move these gradients in time back closer to this RF pulse such that everything happens right after the RF pulse, and then we can measure our signal. Right? And that's called gradient echo imaging, because we're making the image from the free induction decay. We're going to cause an echo in this signal, but it's actually just a refocusing using gradients. And so this is what gradient echo imaging looks like. It's exactly the same as the other page. Just throw out this pulse here. It's gone. We're not going to look at a spin echo. We're just going to image off this signal here. And so we have to push our phase encode gradient back very close to the RF pulse. So this is an RF pulse. This is the next RF pulse, and this is the signal that we're going to make the picture from, make the image. So apply an RF pulse with a Z gradient on, gives us a slice selection. That's cool. And then we actually refocus that slice, because at the end of this pulse there's going to be a phase shift across the slice. So we get rid of that phase shift by refocusing that gradient. We're going to, while we're doing that refocusing, we are also going to apply a phase encoding gradient of a predetermined size. I'm going to step through different sizes for different RF pulses to get a 2D raw data set. And that can occur during this refocusing here. This is all just magnetization management over here. We're going to read out, we're going to digitize our signal during the readout phase of our X gradient here. If we're not digitizing, we can just apply these gradients all together, because all of those phase shifts will just add up in each direction. So we apply the phase encode gradient, and we pre-phase in X such that when we read out with our X gradient on, we will already have applied a negative phase shift in the X direction. And then when we apply the positive shift, there will be a point here where there is 0 phase shift in the X direction. There will be negative phase shift and then a positive phase shift. And so that takes us across actually the DC point in Fourier space where there is no phase shift. And that echo is what is generated by this rephasing of this gradient, and we sample that signal. If none of these gradients were here, and this was a perfectly homogeneous magnetic field, and we applied an RF pulse here, we would see a free induction decay, right? We would just see a signal that comes down like this. It would have an amplitude here that's proportional to the exponent of minus TE over T2 star, if this time is TE, right? So it's decaying away exponentially. And we need to get all of our imaging done before this thing decays away to, nothing. The real advantage of doing this, or imaging in this way, is the fact that we can get all of this done. All of this RF pulse, these gradients switched, this readout, everything completed in about a couple of milliseconds. All right, so that gives us the opportunity then to apply another RF pulse immediately and just do it again. And so, if we were able to switch our gradients fast enough and make all of this happen, say in a millisecond, then we could do 1,000 of these a second, right? So you can make a picture with 1,000 different phase encoding steps in 1 second. So that significantly speeds up MRI when you can do this. In order to do that, these RF pulses are usually not set to 90 degrees, i.e. you don't tip all of the magnetization down into the transverse plane. Most of the time, you tip down about 10 degrees, 15 degrees or something like that. And that gives you a transverse magnetization that you can make an image with, but it doesn't tip out all of the longitudinal magnetization that you have on hand. You can tip it out over time. So there's sort of 3, let's say, zones of what TR values make sense when you're doing images like this, and we'll take a look at those. So in order to make the image, we're going to apply multiple RF pulses, right, one after the other, and they'll be separated by TR, just bang, 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 bang. And we'll step through various phase encoding gradient values. So if we do, let's say we step through 256 values, that's 256 pulses. So we get to set this time delay TR. And it is going to, changing this time delay will change the brightness of various magnetization vectors in the picture. For everything, if you don't have any kind of steady state issues, like when TR is long enough, basically the signal goes like T1 recovery times the exponential decay of that free induction decay, or the gradient echo. So that's a very simple contrast mechanism right there. As TR gets really short, this equation breaks down. It doesn't hold anymore. We'll see that in a second. So let's look at the 3 different classes of pulse trains that we can use to make pictures. So if we use a long TR, when I say long, what does that mean? It means TR on the order of T1 or greater, say 2T1. And if in the heart T1 is 500 milliseconds, if we use TR of a second, that when we do say this is a 90-degree pulse, the magnetization, or the Z magnetization, goes to 0 here, and then it recovers back with T1 recovery. And you can see here it's almost all the way back to full recovery. So this is probably 3T1 here. Right? That time duration here would probably be 3T1. And so that gives you traditional T1-based contrast, in the sense that tissues that have shorter T1 will recover or be more closely fully recovered than those that have long T1. The problem with making images like this is that it takes a long time. So if you take 2 seconds for each TR, then you have 512 seconds to make a 256-step phase encode image, right? That's too long. Well, that's a long time. There is a way of using your time more efficiently in MR when you're forced to use a long TR. While you're waiting around for this magnetization to recover over this time, you can go off and image another slice. Right? Because remember, these are slice selection acquisitions. So if I select a slice here and then read out my signal, and all I'm doing is waiting around for the magnetization to recover, I can move a few centimeters away or a few millimeters away, excite another slice, and image that one. And then move, excite another one, and image that one. So I can go all the way down the patient, and if this is 2 seconds, I have 2 seconds worth of time to scan through there, flip back around, and then start again. Right? So it can become pretty efficient, right, when you do this multi-slice acquisition. The issue with doing that is that if the slices become too close together, the RF pulses from one slice start interfering with the contrast in the next slice. And you start getting crosstalk between slices. And the contrast mechanisms aren't simple anymore. It generates artifacts. And so you need some gap between the slices usually to keep everything simple. So oftentimes if you're doing a multi-slice experiment, do those slices, they'll be separated by one slice gap. So you'll leave a slice in between, and then shift the whole thing and do it again, right, on your next acquisition. Okay, so that is usually the multi-slice mechanism. You have an RF pulse, free induction decay from which you can make, or acquire your image data. Sometime later, you do it again, and you get another free induction decay. If we push the TR such that they're shorter, and now in the medium range, this is what I mean when TR is, actually this is a typo. This should read TR as approximately equal to T1. That's probably a copy-paste error. Let me fix that right now. TR is approximately equal to T1. Okay. Then we see that the magnetization doesn't recover to its full M0 value by the time the next RF pulse comes along. So our first RF pulse, we start with magnetization of its maximum value M0, goes to the transverse plane, and then it recovers back, and then we apply another pulse before it's fully recovered, and then that goes down and starts the image, or we get the free induction decay. It recovers back. Before it gets back to M0, we apply another RF pulse and use that. So after the first pulse, we have a steady train of values that have the same amplitude at each RF pulse. And that amplitude is strongly proportional to the T1 value. When this delay here is set to on the order of T1, the amplitude here is strongly dependent on the T1 value. So as T1 gets shorter, pixels get brighter. As T1 gets longer, pixels get darker. So this, if you are interested in T1 contrast, this is a good way to do it. And then there's a whole other domain of MRI in which the TR is set to a very short value, say 2 milliseconds. So it's extremely short when compared with T1, and it's extremely short when compared with T2. So the T2 decay, remember, is the magnetization in the transverse plane, and it's decaying away. And what we're saying now is we're going to apply the next RF pulse before that magnetization in the transverse plane decays away. And so you start getting signals that look like this. Right? And this is called an echo train. And this becomes a steady state signal that is proportional to T1, T2, and the RF tip angle. It's called oftentimes it's called steady state free precession, or SSFP. And you can maintain a fairly high signal value by just maintaining these RF pulses at short delays. And it turns out to get a good echo train, you usually need a relatively high tip angle of that RF pulse, sort of on the order of 45 degrees or something. And then you get very bright signal from a lot of tissues. And if we go back, this is an example of an image obtained with a TR set to, say, 4 or 5 milliseconds, and the flip angle set to somewhere between 20 and 45 degrees, and you get these very bright signals, right? From blood, from CSF, from fat, and the TR is really short, like really short, down in the 2-5 millisecond range, something like that. So these images come out really quickly. The machine itself, when you're making an image like this, makes a very high-pitched sound, right? Because the gradients are switching off and on at a really high rate, and a high or low repetition time, high frequency. And so the audio of this sequence is a high-pitched sound. Okay, so those are the 3 domains of TR and how we generate contrast with them. So any questions about that? So usually the thing that limits this type of acquisition, the SSFP acquisition, oftentimes is the amount of RF that you can essentially transmit into the patient, right? Because if we have relatively high tip angles and they're only a few milliseconds apart, that's a lot of RF going into the patient compared to this. And large people will heat up when you do this, right? And there's certain guidelines for how many watts per kilogram you can use when you're imaging a person, such that you don't heat them up over an amount that they are incapable of basically, reducing through normal methods like circulation and breathing and stuff like that. Of particular concern are body parts that don't have great circulation. So the circulation is the thing that takes the heat away, and so your eyeballs and things like that that don't have high circulation, you don't want to heat those up. Right? So we can look at T1 weighted imaging with CMR for trying to image relative perfusion of myocardium. And this is very similar to SPECT in the sense that we're injecting a contrast agent. That contrast agent is going to go to different compartments, say the heart, and then if there is high perfusion in the heart, you will see the signal will get brighter because the T1 gets shorter as the contrast agent goes in. So this is a stress-rest MR pair of images in which, in the rest case, we're getting enhancement. You can see the blood pool is enhanced because the contrast is in there. We're getting enhancement of the myocardium. So it's like a uniform brightness. And then when we apply stress, and if you recall how we apply stress, we usually give the patient a vasodilator like adenosine, which opens up all of the vessels and drug-induced way asks for a lot of blood flow in the myocardium. And if one of the vessels is incapable of reaching that flow rate, you will see a shadow or a dark spot here in which the contrast agent didn't get in there at the rate at which it's getting into the normal myocardium. And so this is a positive stress test on MR in the sense that you get this darkening here. In this paper, the authors claim that they confirmed this both on CT and MR in this patient. Fair enough. But you can see in CT, even though the image quality is quite high, the resolution is much better than MR. You trust the edges better, and there's all these fine structures you can see. The actual change in Hounsfield unit, like during the injection in the myocardium, is very subtle, right? So this person's positive on MR. This is a, everybody's going to call this positive, and you're going to be right with this guy. Here you can see that's a pretty subtle thing on CT, right? So unfortunately, because on CT, all you're measuring is the relative absorption of X-rays. So the contrast concentration of the agent in CT, the difference between concentration between here and here isn't really that high. It isn't that high either in the MR. However, on the MR, what the contrast agent is doing is it's changing the T1 of the tissue, and so it makes, even a small change in concentration makes a fairly large change in that relaxation rate. And so it amplifies the effect. So I would say of all of the imaging modalities that we have looked at, this is the way you should measure myocardial perfusion. MR seems to be the rock-solid method for doing this. So if the physiology works at all, i.e. the stress test works at all, then MR will be able to pick it up. Sometimes the physiology doesn't work. A person can have a relatively high-grade lesion upstream and still their stress test looks fairly normal. They just get around it. Their heart has figured out how to get around it. And so that is a cause of false negatives, right? If you're using this to detect a lesion that you want to treat and you miss it, then you've got a false negative on your hands. And so MR is pretty solid in terms of its sensitivity. But again, the whole stress test procedure itself isn't perfect. Right? That's why combining the stress test procedure with CT, in which you have a very high-resolution picture of the coronary arteries as well as this change in intensity, should be more specific, right? More sensitive and more specific. So here's an example of some data that was obtained by a group in Britain in which they looked at fractional flow reserve in patients, and so the FFR was used as the underlying truth as to whether or not there was a significant lesion in the patient's coronary. And just to recall what FFR is, you put a catheter in the coronary artery itself that has the lesion. You measure the pressure in the root of the aorta or in the proximal location in the vessel. You push that pressure catheter across the lesion and you measure the pressure distal to the lesion. And you do that when you inject adenosine. So you stress the patient. And then you look at the difference in pressure across the lesion. If there is no difference in pressure across the lesion, that lesion is considered non-severe, right? So it can keep up with the flow demand. If, on the other hand, the pressure distal downstream drops by more than 20%, then you call that a significant lesion, in the sense that it has a hemodynamic effect on that vessel and on that patient. So that is now the gold standard for determining if you have a significant lesion on your hand, not just the geometry of the lesion. Because the geometry of the lesion can vary a lot, and you can have a really tight lesion that you don't see a positive FFR, and you can have a 50% lesion where you do. So FFR is on this axis, and they've made two buckets. Okay? This bucket, the FFR is below 0.75. That means greater than 25% drop in pressure across the lesion. So this bucket are the patients who are positive FFR. This bucket are the patients in whom the FFR did not achieve a 25% drop, so greater than 0.75. And so these are considered non-significant. This axis here is the myocardial blood flow estimate divided by resting flow in terms of the hyperemic response on the T1 weighted image. So if we go back to the picture, in the normal tissue, when I look at my rest and then I look at my stress, the ratio of the signal here to here is like the hyperemic response. Right? In this patient, that ratio here is less than 1, right? In this location, because it looks like it almost got darker than this tissue. Okay, so if it's less than 1, that's a big problem. The patient, their flow actually goes down during stress. So you can see here's 1, so there's a group of patients in which you got a dark response on the MR. But there are a group of patients in which the hyperemic response is greater than 1, right? But not as much as the normals. Okay. So the claim by these authors is you can draw a line here on the hyperemic response as your threshold for calling whether or not a lesion is significant. To me, there's an issue with this data, right? I mean, whenever you read papers, you should read them with an open mind. Right? It's like, if a graduate student brought me this data, do I believe that data? Right? I mean, when you look at this data, does it look rational? Does that data look like that would happen? I don't know. This looks a little magic to me. It looks like half of a Gaussian. It just got cut off, right? I'm not really sure what happened here, but this does not look like a normal distribution in this direction, right? So we'll see. This is why when you're doing these kind of threshold experiments and trying to set thresholds for a whole population, you need large numbers of data. Granted, there is a huge group here in which there's no question you would just say they're negative, right? So it's of value, right? This group in here, there's still going to be a chunk, 20% or something that you're flipping back and forth. You don't really know. So I think it's very valuable data, but this looks a little weird to me. I don't know if it looks weird to anyone else. But. Okay, so that's T1-based increase in signal during contrast injection. Right. So we figured out how to do T1 weighting. Now recall from last time when we were looking at methods, if we look at the concentration of the contrast agent as a function of position in the patient, we have the contrast agent in the blood pool. It's just being cleared by the kidneys, and so if you measure the T1 value, say in the left ventricle, as the contrast agent gets higher and higher, the T1 gets shorter and shorter and shorter. And so basically the signal will get brighter and brighter, and then it will come back to normal. Normal myocardium follows the blood pool, only it's delayed by, 10 heartbeats or something. Because it essentially the contrast agent mixes in the blood pool, comes back into the heart, goes out the aorta and down the coronaries, and then that's what perfuses the myocardium once that contrast agent gets down the coronaries. And so that's going to be delayed from the blood pool, and the peak is going to be somewhat smaller because the concentration is going to be less. So the myocardium, normal myocardium, has this type of picture. And as we saw last week, both in the lecture and in the presentation of the paper, infarcts have this wonderful ability to retain contrast. And so they become very bright out here. Right? Once everything's gone back to normal, an infarct or damaged tissue will remain very bright. And I think this is probably one of the most valuable imaging applications of cardiac MR, is looking at a very precise picture of the damaged tissue. If someone has had a heart attack and you want to know how did they fare after that heart attack, how are they looking, you do one of these pictures, the delayed enhancement pictures, and you can see how they're doing. Right. So let's take a look at some of the details about making these pictures. So this is two graphs of the longitudinal magnetization as a function of time. And this is the magnetization in the scar, and this is the magnetization in the normal myocardium. And the normal myocardium, the contrast agent has washed out at this point, and so its T1 is longer than the scar in which the gadolinium has been retained. Right? So we have short or a faster recovery towards equilibrium in the infarct. And so what we can do to create the best contrast possible between the normal myocardium and the infarcted tissue is we could apply a 180-degree pulse, and that inverts the Z magnetization from M0 to minus M0. And so it starts at 0, and then after the 180, it's down here at minus M0. And both the infarct and the normal myocardium start at minus M0. And then the infarct climbs back towards equilibrium much faster than the normal myocardium. And over the years, what people have iterated towards in terms of imaging is they try and make a picture, an MR picture, at the time that the normal myocardium is crossing 0. Right? So when the magnetization is no longer negative or positive in the Z direction, we'll make a picture then. And so the background will be 0, and we'll see a bright infarct. Right? And that's called the null point. And so oftentimes when people make these late gadolinium enhancement images where you have bright infarcts, they will seek out the null point by doing a couple of test scans at different delays. So they'll do a 180-degree pulse, set a delay here, this is called a TI value, and see what the contrast of the myocardium looks like. So if the TI value is here, contrast will not be 0. If it's here, it won't be 0 either. So they hunt for that 0. And that's a bit of a I think, unfortunate historical accident, but anyway, that's oftentimes how this is done. And so here let's look at 3 cases in which the TI value, that time between the preparatory pulse, the 180-degree pulse, and the image itself is changed. So in A, we do a 180-degree pulse, and then at a very short TI, we make a picture, and so our relative values of the magnetization are here. And we can see that the myocardium and the infarct, this is the good image, here's the infarct here, have approximately the same value. The myocardium obviously is still negative at this time, so it's still below 0 because when you make an image of, of the magnitude of the magnetization vectors, we're getting an averaging between the myocardium and the blood. And the myocardium is negative magnetization. This is positive. And so where they meet, it becomes 0. And so you get this very interesting effect or artifact, whatever you want to call it, in which the partial volume of the blood and the myocardium here give you an outline. Same thing will happen around the infarct. You'll have normal myocardium around the infarct, and you'll get a dark outline. If we take another image and we increase the delay, right, then this signal itself will become darker when we make the picture because we're moving towards 0. We're still not at 0, but we can be down here. So the myocardium moves towards 0 and becomes darker, and the infarct is recovering more. It becomes brighter. And then at C, where the myocardium is 0, we have our highest contrast with this acquisition between the myocardium, the blood, and the infarct here. And then on D, if we make our image a long time after the 180-degree pulse, we see that everybody's recovered. The myocardium's up here, the infarct's up here. So this contrast is up in this direction. So achieving this picture requires knowledge of where the myocardium crosses through 0, which is unfortunate. And the reason that's done is that traditionally when you make a magnetic resonance image, you just look at the magnitude of the magnetization. You don't look at its phase. And it just made a lot of corrections easier if you ignored the phase, because many things can change the phase. Motion, magnetic field offsets, a whole bunch of things. And so when you try and make a phase-sensitive image, you get all these phase shifts across the field of view that you don't see on a magnetization magnitude image. That's what all of these are, magnitude images. If you get rid of those phase shifts, the artifactual ones, then you can make an image of a negative magnetization vector. It actually, when this signal is positive, this will be negative. Over here, this would be very dark. It would be less than 0, right? And so basically, all of these images, when you do phase-sensitive reconstruction, look about the same, right? And so you don't really need to determine where it crosses 0, because all of this contrast is quite constant over a broad swath. So if you can do a phase-sensitive reconstruction, you can achieve the same image here, 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 here. And so that is, certain manufacturers have pushed towards that. And for example, Siemens does it traditionally, GE does not. And so you're stuck with this, finding out where the null is. So here's an example of a phase-sensitive image in which we have negative magnetization and positive magnetization in the infarct, right? So here, this is a much more robust way of maintaining contrast between the infarct and the background. You just have to correct the other reasons why the phase shift changes over the picture. So the true value, I mean, the real value of this is the fact that you can make super high resolution pictures of infarcts. And so if a patient, so in this patient, you can see, oh, it looks like under stress there might be a reduction in flow. How is this person's myocardium doing? You don't really know from this picture, from these pictures, from these perfusion pictures. But then you do an MR in which you do this late gadolinium enhancement, and you can see this little rim of infarcted tissue there. Very small amount of tissue on the endocardium has been infarcted. And the rest of this is normal, right? So you get a high-resolution image of what the state of the tissue is. And so that's, I think, its real value. And if you want to really understand what an infarct looks like, you can do a offline image, at super high resolution. Just put, if you have a heart in a jar from, let's say, a porcine infarct, and you image that thing, this is what it looks like with standard clinical resolution, where your pixels are 1.5 millimeters by 1.5 by 8 millimeters. That's kind of a standard MR clinical resolution. This is what it actually looks like. That's when you image the thing, in a jar for an hour and a half, such that your voxels are now 250 by 250 by 250 microns. So sort of CT style resolution. So it's quite extraordinary, the difference between what you see on a clinical image and what's actually under there, in terms of the details of the normal tissue that's interdigitated inside that infarct. And if we zoom that up, here it is in clinical resolution, right? And that's what's actually under there. So we've used these high-resolution images to try and model electrical abnormalities running through infarcts, because normal tissue that's inside here will get excited, and the electrical excitation will run through there. It just runs through more slowly than in a normal tissue. And so it would be great if you could make pictures like this in people and then do a simulation to determine whether they need a defibrillator. The problem is making pictures like this in people that are alive is very, very hard. I tried for 5 years to do this. One of the best state-of-the-art imaging equipment that we had just received at high field strength, with the most advanced motion correction and selected gating stuff. And the problem is, at 250 microns, the heart just does not come back to the same place, beat to beat. So your resolution is essentially governed by the fact that those heartbeats are not coming back to the same spot. And we tried and tried and tried, and one guy spent his whole PhD doing that, and did not get an application that you hit a certain resolution, and then you just can't seem to get beyond it, and it's very frustrating. Anyway, so these are high-resolution images of different infarcts, and you can see they vary remarkably in terms of what normal tissue is left interdigitated inside that infarct. And this, where you have this mixture of normal tissue and infarct, in clinical MRI they call this quote-unquote gray zone. And so it's not a full-on bright infarct, and it's not a full-on normal myocardium. It's kind of a mixture, and it's called gray zone. So you can also look at the evolution of the infarct in a patient over time. And so here's a patient scanned with late gadolinium enhancement 1 week after they had their heart attack. And you can see that there's dark spots here. There's obviously an infarct right at the apex. This dark stuff here could possibly be basically microvascular obstruction, that the contrast just can't get to that part of the heart because the vessels have all broken down. So you see this in the acute phase, and then this is what that patient looks like 4 months later. Right? So there's an evolution of this tissue that goes from this acutely damaged tissue to a chunk of tissue that's repaired itself through fibrosis. So it's made a scar, essentially. So here you had a very fresh insult to the tissue. The tissue would look all swollen and hyperemic in a way. And then here you'd see basically a scar. So you can, through the appearance of the myocardium determine how old that insult is, right? So we've done patients who are completely asymptomatic, you know, they're in for some other reason, and then you look at their heart and you go, hey, there's something going on in their heart, and you know, the gadolinium is lighting up certain regions, and it's obvious they had a heart attack at some time, but they just shook it off. You know, it's like, oh, I got pain, gosh, and then it goes away, and then they're left with an infarct there. So it's pretty interesting, and you can tell how old it is sort of by the brightness and the look of it. So let's go back. We got rid of the spin echo for a while because we were looking at really short imaging acquisition with short TR. And now let's say, well, is there any reason why you want a T2 weighted image? So should we put this spin echo back in for some acquisitions and see what the true T2 value is in that tissue, or what the T2 weighting is? T2 weighted image means long T2 would show up bright and short T2 would show up darker, but the image values themselves are not equivalent to the T2 value. They are just proportional to. That's T2 weighted. You can also make an image that is the T2 value of each magnetization vector. It's harder. It's susceptible to noise because you have to fit the value and everything. But are they useful? And so let's review this diagram. As you recall, the transverse magnetization decays away. A simple exponential decay. Long T2, like water, you know, lasts longer than short T2, like muscle. We see the signal decay away. It'll show up dark. So let's look at a couple of patients here. This patient is an acute MI. So this person's had acute coronary stenosis, probably had a ST elevation, came into the hospital, had a heart attack. Right? And then this is their image with T2 weighting. That means long T2 shows up bright, short T2 shows up dark. And you can see in the myocardium there's a large area, a large penumbra, in which we have high T2 values, long T2 values. So what this is the cells have undergone an insult and they are edematous, so that they swell up. The tissue at that location swells up. So when you have an injury, often you get tissue swelling, right? If you burn your arm or you burn some tissue, you'll see it puff up, right? That's edema, and that occurs in the acute setting. When you do, at that time, late gadolinium enhancement on that patient, you would think, oh, I have all this high T2 value. That does not look normal. I probably have an infarct there. Turns out you do not, right? That tissue has not yet infarcted, right? And so the interesting value here is this person has acute damage, but the tissue itself is likely highly salvageable. So you should go in and rescue it by doing a stent or bypass or something. You should rescue this tissue, right? Because it's not dead yet. That's a good thing, right? On the other hand, this T2 weighting, we see there's very bright T2 on this lesion in this patient. There's a central core that is dark, which likely means, you know, there's some kind of iron deposition or something causing the T2 to get really short in the center of this. Remember, this doesn't involve contrast. This is contrast agent. This is just natural T2 values in the tissue. In this patient, when you do the late gadolinium enhancement, you can see definitely there's dead tissue as a rim around this dark tissue here. And this dark tissue is truly dead tissue where the contrast agent doesn't even get in. Right? So the vessels are busted up and everything. This is called microvascular obstruction. And that's probably the worst state the tissue can be in. So. And here's basically relationship of the area at risk on a T2 weighted image versus the infarct size at some time later. And normally the infarct size is a little bit smaller than, so the T2 area can be, cover a large region from 60 to 20 in this region here for those infarcts that show up as 20% of the LV. Right? So normally the T2 shows a larger penumbra of potentially damaged tissue than the infarct that evolves in that patient. So we got 5 more minutes before we have our presentation. So flow imaging is another thing you can do with MR. It counts on the fact that if we put a gradient, if we apply a gradient so that we cause a phase shift in the spins as a function of position, and then we apply the opposite gradient to undo that phase shift as a function of position, for static spins or static magnetization vectors, if they're not moving, by the time this bipolar gradient is played out, they will return to exactly the same phase shift they were at when we applied the gradient. Okay, so positive, negative, positive brings us back here. However, if a magnetization vector is moving along the direction that this gradient is applied, then the phase shift that accrues when you do the refocusing pulse does not equal the phase shift that accrued during the encoding pulse. And so you get a delta phase shift in that moving magnetization vector. And that delta phase shift turns out to be linearly proportional to the velocity. Right? So that net phase here. So we can measure this net phase and then just put it up on the screen as an estimate of the velocity. Right? And so here's an example where we have a cine acquisition of a patient's heart, and then we're looking through a section of the outflow tract of the aorta, and you can see the brightness and darkness here is the phase shift that accrues of those spins as they're moving through the slice when a bipolar gradient is applied, and the brightness is proportional to the velocity. So you can put a cursor on here and measure the velocity as a function of time, right, for those spins. Now remember, this isn't done like echo, where we have Doppler shifts giving us this type of velocity in real time as we have the transducer on the patient. Just like any other MR image, we have to do repeated heartbeats here and put this data together to make this movie. And that usually takes about 8 to 16 to 32 heartbeats, something like that. But you can get very high resolution pictures of these velocities at arbitrary angles through the heart. Whereas with ultrasound, we were limited by the orientation of our transducer. Here we can orient the slice that we're going to image flow in any orientation, right? And so it's quite convenient that way, specifically in congenital heart disease where the orientations can be quite strange and you need to program them. And so here's some examples of, it's called 4D flow, where we've mapped, this is from Albert Schau, who's here at UCSD, where you let the patient breathe and you acquire images for about 20 minutes and you make a full 3-dimensional displacement field at multiple time points through the heart cycle. And you can plot the velocity of the blood and the direction of that flow, superimposed on top of the magnitude images, which is very powerful in hearts that have very strange geometry and orientation. And so here's an example of a mitral leak, like a jet, a tricuspid regurgitation jet right here, that's obtained in a location that is hard really to capture, say on echo or some other acquisition. Okay, so we'll pick up there next time. And now I think Dimitri and Kathleen are going to give us a talk about CT reconstruction.